Hi, I'm Dr. Ashley Fuller.
And I'm Dr. Meredith McClure.
And this is Labia Logic,
the podcast that's all vulva, no filter.
We're here to talk about all the stuff your doctor rushed through, the questions you've been too embarrassed to ask, and the sex ed that barely mentioned the vulva.
Because too many people are suffering in silence with painful sex, menopause misery, and vulvar issues no one talks about.
No shame, no stigma, just real talk, real answers, and the education you should have gotten in the first place. Welcome back to Labia Logic. We are so excited to be here. Meredith and I are here, and we have a special guest today. Dr. Jill Krapf is joining us, and we're going to be talking about the clitoris and clitoral pain. And I wanted to introduce Jill. Jill is a gynecologist and vulvar specialist and a leading expert in vulvar pain and sexual health. She's the founder of the Center for Vulvovaginal Disease Disorders in Florida and Tampa. She specializes in diagnosing and treating vulvar pain, vulvar dermatoses, overactive pelvic floor dysfunction, vulvar lichen sclerosis, recurrent vaginismus, and menopause. We look up to her and have learned a ton from her over the years. She also does a lot of research, publishes a lot of great research articles on these topics, and has co-authored 2 books, When Sex Hurts, Understanding and Healing Pelvic Pain, and the textbook, Female Sexual Pain Disorders. Thank you for being here with us today, Jill.
Oh, I'm so excited to talk about this topic. This is the best topic.
One of the things that's so important about this topic is that it's not talked about enough, right? I was amazed how we were not even taught to examine the clitoris in residency. I don't know if you were, Jill, but we were not.
No, not at all. And I have a funny story about it, actually. So I was a clerkship director for many years. So I taught medical students how to be OBGYNs. And I actually had a male medical student get in trouble because he examined the clitoris.
What?
Yes. The patient felt very uncomfortable because she had never had her clitoris examined before. Of course, there was probably some communication things that could have been a little bit better, but that's where we were coming from. Granted, this was 10 years ago, but that's where we were coming from, where it was not expected that we would examine this part of the anatomy. And when someone did, it was deemed out of the ordinary. I don't think we've come that far, honestly.
When I kind of started getting into this, I went to the anatomy lab to learn, and this was just 5 years ago, and there were residents in there doing dissections for urogynecology procedures. And I told them about what I was doing, and they were like, "You look at the clitoris in clinic?" And I said, "Yes." They're good. "Do people know you're doing that?" I'm like, "Yeah." We tell them that they don't feel me necessarily. It's just retracting the clitoral hood to make sure that you can. Even now, the trainees are not trained to look at it.
No, and it's an essential part of the anatomy. We need to be examining the clitoris. It's a part of the vulva. We need to be examining the vestibule as well, which I'm sure we'll talk about. But the clitoris, especially, and the pelvic floor while we're at it. But yes, this episode is dedicated to the clitoris. And I think that is wonderful because we spend so much time on other pain conditions. We rarely talk about issues with the clitoris.
I think it's so important. We talk about this in a lot of our podcasts, but the vulva is at least in residency was kind of a flyover state. You just kind of went right through it, put speculum in and did the pap smear, and it didn't get enough attention. And then even, if you did happen to look at the vulva, you didn't get taught to look at the clitoris. So I always tell patients when I'm examining, I'm going to look here because no one else looks here. You can't see here very easily. And I'll tell them before I do, I'm going to retract your clitoral hood and look at your clitoris. And most of them have said no one's ever done that, because no one's taught to do that. So yeah. So I'm excited that we're talking about this because I know for Meredith and I, and I'm sure Jill even sees more of this than us, that I see so often patients come to see me for clitoral pain. It's becoming more of a conversation in kind of social media and, about clitoral adhesions. And I think, even this week I did 3 licenses of clitoral adhesions in my office because I don't think many gynecologists or clinicians are doing this. And I think it's super important. I see patients have really good results from these lysis of adhesions procedures. So I'm excited to dive in and talk about all this. So our previous episode of this, we talked about the anatomy of the clitoris. So just to remind everyone, it's not just the part of the clitoris we can see with our eyes. Remember the clitoris, we can see the glands of the clitoris and the prepuce of the clitoris, but we cannot necessarily see the wishbone parts or the glands, other parts of the clitoris. A lot of erectile tissue and things like that, but it's not just the parts we can see. So remember, there's more there than what meets the eye. But let's talk about, what clitoral pain is like. What do people usually present with when they're coming in with clitoral pain? Tell us what kind of patients you generally see with clitoral pain, Jill.
The way that I like to think about clitoral pain, and it's actually easier than some of the other types of pain conditions, there's two pathways. There's structural and there's nerve related. And it's really as easy as that. So when they're coming in, people will describe it many different ways, or more commonly, they don't, right? They don't tell you. So you'll examine because they have another issue, whether it be a dermatoses like lichen sclerosis or what have you, or chronic vaginitis. And when you're doing the exam, you'll see something structural like clitoral adhesions, and you'll touch with a Q-tip and they have tenderness or discomfort. Then I start asking the questions. Are you able to orgasm? Have you feel like your orgasm has changed at all? Is it harder to orgasm? Do you like your clitoris being touched? And oftentimes people that have clitoral adhesions will say the same thing. They'll say, I really don't like that area being touched. I feel really uncomfortable when my partner tries to touch that area. I really don't like receptive oral sex. I've never liked it. It's always felt like too stimulating. It's always felt like in a bad way, right? Like too stimulating in a bad way. It's felt uncomfortable. It's felt itchy. It's felt, there's so many descriptors that people use. It's really varied how they talk about it once they start talking about it. I think with social media, with Reddit, with the information that we now have out there, and with normalizing this, more patients are coming with this as their primary complaint, but that has not historically been the case at all. They usually have something else, and then you discover it, and then it opens up this box of, oh my goodness, they have all of these elements of sexual dysfunction related to this, and they didn't lead with that at all.
Yeah, I think I see more people lately that come in with clitoral adhesions, but I definitely find clitoral adhesions on exam quite often. And I think it's an important, finding on the exam that can kind of connect some dots to their other pain things that they have going on, or to their sexual dysfunction for sure. But I like the way you think about it, like it's either structural or nerve related.
There's been two studies that have looked at prevalence. One found 22% of people had clitoral adhesions, and these were people presenting for sexual dysfunction or to a clinic that specialized in it. Another one found 33%. But I think it's also important because I see a lot of patients with autoimmune skin conditions that cause scarring, like lichen sclerosis of the vulva and lichen planus. I see a lot of these patients, and it's important to note that there's a difference between clitoral adhesions and clitoral phimosis, or coverage of the clitoris, and we can talk about those. But also, there's a lot of patients that have clitoral phimosis, or coverage of the clitoris, even completely, that have absolutely no symptoms of clitoral pain at all, and no issues with orgasm at all. They're able to orgasm. The quality has not changed. There's absolutely no sexual dysfunction. You just can't see the glans clitoris, or that tip of the iceberg, because it's covered with the clitoral hood, or with combination of that and scar tissue zipped down over the clitoris, but they have absolutely no dysfunction. I would say the people that have the most pain are people that have, number one, clitoral adhesions, or that tethering, and people that have partial coverage, not full coverage.
Yeah, that's really interesting. Sometimes when I'm doing an exam and you'll see it's completely phimosis, I'll ask them, do you have any trouble with orgasm? And they don't. It's a really good point.
And this is something that deserves study. This is something that we see clinically, but it's not well documented or described in the literature. But it's very important because when we talk about these conditions, there's going to be people that have lichen sclerosis or lichen planus that say, oh my goodness, I have complete phimosis. Do I need to do anything about it? And what I always tell people is, if it's not broke, don't fix it, right? If you don't have clitoral pain, if you don't have decreased orgasm or an effect on sexual function, and it doesn't bother you, those three things, then there's no reason to have a surgical procedure or anything else to correct your clitoral phimosis, right? Because you have function.
I see more people, at least I'm hoping, as they see me and just kind of more talk in social media, like people are becoming a little more aware of their vulva. Sometimes I have patients that come in and say, well, I can't find my clitoris anymore, and it didn't used to be like this. And then you ask them and they may or may not have symptoms, but I think it's hard for the people who don't have any symptoms. Like I'm always thinking, well, do we really want to go down a path of having a procedure that it's not going to change your function, right? And then ultimately you may need another procedure, and it's kind of setting you down a path of like, multiple procedures when you're, not having pain and not having sexual problems. So, but, people are more noticing their own anatomy.
Exactly. And, I think that it's important for us, especially those of us that see a lot of this, to really say, okay, if it's not affecting function, if you're not having pain, then it's completely fine to treat your skin condition, but to not uncover the clitoris because there's risks to all of these procedures as well as benefits. Yeah,
Sure.
Absolutely. Speaking of definitions, I think that's important because there's an overlap, but there's also a difference between clitoral adhesions, which often cause pain, and clitoral phimosis or coverage. And so to get to the bottom of this, myself and some of my colleagues, some of the people Dr. Rachel Pope, Dr. Rachel Rubin, Dr. Melissa Moskar, and Dr. Kylie Moss. So it was basically 3 gynecologists, a urologist, and a dermatologist walk into a bar. And so we all got together and we decided, we're like, we need to give definitions because if we raise awareness for this, we need to know how to talk about it. We also need to know if we're going to highlight treatment options, we need to know what we're treating, right? So we did a Delphi study, basically tapping into experts who treat clitoral adhesions, clitoral phimosis, clitoral pain, if you will, to see what the expert consensus was on definition. And we presented this at ISWISH where it's in the works to be for publication. It's like pretty soon. But I will share because it has been presented already. So basically clitoral phimosis we described as the inability to retract, meaning the inability to pull back the clitoral hood off of the glans clitoris. So that's clitoral phimosis, whereas clitoral adhesions are the tethering of the clitoral prepuce or the clitoral hood to the glans clitoris. So different, and they can occur together, but what we find, and this isn't well published, but what we find from experience is it's the tethering, it's the adhesions that tend to cause pain, not necessarily just coverage without adhesions.
This is great. I mean, to even just make this a standardized thing where people can be taught this and utilizing it even in clinical practice of these are the symptoms that we look for to treat it and when do we treat it and to what degree. And I mean, you think about like pelvic organ prolapse and they have degrees of prolapse and certain things you can do. I mean, this is amazing that this is being done and talked about.
It's much needed because we don't have billing codes for any of these things. So when you're talking about procedures to correct something, you have to have a definition. It's like the first step, right? To even get a billing code someday, hopefully, so we can hopefully get coverage for these very necessary procedures in the future. But right now we're working with hardly anything, trying to get coverage for this because there's not the words, there's not the definitions that even exist within the billing code, which is really unfortunate. And then, as we pointed out, the next step is really classification, to describe classification. So once we have the definitions down, then how do we classify this? And how should we classify it? And basically, the first step was the experts expressed that it would be better classified as either all or nothing or as mild, moderate, or severe, as opposed to classifying it, for example, as a percentage, right? Because it's hard to know when the clitoris is covered to any extent how large the actual glans clitoris is. So it's hard to really give it a percent unless we uncover it with a procedure and then retroactively assign a percentage. So they decided that mild, moderate, and severe would be an appropriate classification. So the next step with this study, after we publish this part, we have images of different classifications now that we have one, and we're going to basically test that with the experts to see what the inter-rater reliability is. Like, do they agree? Do they not agree? What is determined to be mild? What is determined to be moderate? What is determined to be severe? All of this is very necessary.
We know it happens with like sclerosis and things like that, but there's even other reasons people have clitoral adhesions, and we don't even know the extent of why and to what extent and all that. It's just a Pandora's box of information we don't haven't unlocked.
Inflammation likely plays a role, but there's different forms of inflammation, right? There's the autoimmune inflammation that's involved with lichen sclerosis and lichen planus, and we know that those conditions are associated with at least clitoral phimosis. But there are other inflammatory conditions such as desquamative inflammatory vaginitis, which describes basically a vaginal discharge with signs of inflammation, meaning white blood cells when we look under the microscope. So we know that that's very inflammatory. And I think what's really interesting as we're unraveling this is that DIV, or that inflammatory vaginitis, we believe has 3 general contributing factors or causes, right? It can be related to a lack of hormones. So we used to call that atrophic vaginitis. So we know that a subset of people with GSM, or genitourinary syndrome of menopause, meaning like the ovaries aren't working as well, or they have another reason why they're hormonally deplete, both estrogen and testosterone at the vulva. We know that a subset of those people have an inflammatory, yellow, sticky discharge, high pH, that's sounding very much like DIV. So lack of estrogen, or lack of estrogen testosterone, if you really want to expand things, is one potential cause of DIV. Another cause, it's associated with erosive lichen planus. So when there's erosions, and that can include a cervical ectropion, meaning glandular tissue on the cervix as well, which is a whole other subset of, and that's not lichen planus, of course, but that's another subset of a source of inflammation. So there can be basically generators within the vagina due to different conditions that can contribute to an inflammatory discharge. So that's the second part of it. So hormones and then inflammation. And then the third is aerobic vaginitis. So a combination of aerobic bacteria that contributes to an inflammatory picture. And that obviously differentiates it from bacterial vaginosis, which we generally think of as non-inflammatory in the sense that there are not white blood cells when we look under the microscope, just in that sense. But DIV, I do see a connection no matter what it's caused by, whether it's lichen planus, a cervical ectropion, aerobic vaginitis, or GSM. We see an association of DIV with clitoral adhesions. There's always an element of phimosis when there's adhesions because they're tethered, but with clitoral adhesions, we see an association.
I can definitely see just from my own experience in doing a fair amount of the procedures, I hadn't really thought about how phimosis and adhesions are different, but I definitely have some LS, lichen sclerosis patients who the hood is just tight over that. Like the clitoris seems small and the hood is really tight and it's really hard to retract it, but it's not really stuck to the clitoris.
You got it.
But I feel like I see that more in lichen sclerosis, like you're saying in dermatoses, than I do in someone who doesn't have a skin condition and just has what I can see, these like subtle, maybe sometimes not so subtle, but like filmy tight adhesions to the clitoris that are more painful.
Yes. And when we think of them as separate processes, it kind of steers us to a root cause. It allows us to find a more targeted treatment option and to counsel patients in a better way as far as recurrence.
Yes, definitely.
For sure. Because if it's a dermatosis, then you're going to treat the dermatosis, and that potentially could help prevent the inflammation.
If we can modify the inciting factor, right, then whatever procedure that we end up doing is going to work better because the actual thing that caused it in the first place has been treated, ideally. So that's going to affect our rate of recurrence and decrease our rate of recurrence. So for example, with lichen sclerosis, I will never operate on someone's clitoris unless they're 100% in remission from a lichen sclerosis standpoint. Same with lichen planus. They have to be in remission, no activity, no patches, no thickening of the skin, no lichenification, no active erosions, etc. And that's going to decrease your refusion or your recurrence rate. But we need to have the same idea when it comes to causes of clitoral adhesion that are not vulvar dermatoses. So if you don't treat someone's DIV and you do an in-office lysis, guess what? It's going to come back, right? So we really need to treat their DIV first before we can do the lysis. Or if we think there's a hormonal element, I like to correct, the GSM component even around the clitoral hood and the clitoris with a topical And I like to do that anyway because they just have better healing. I think the keys to this are going to be to figure out where the inflammation is coming from so we can decrease our recurrence rate.
Yeah. And sometimes those adhesions are so tight.
Yes.
Like it's like a vice grip.
Exactly. And it makes sense. I mean, when you see it, you're like, how could this not cause discomfort? How could this not cause pain? And what's very interesting is even if someone does have, they're like, oh, I don't like that area to be touched. They really have like a nondescript, or like, when underwear or the seam of my jeans runs, across it. Oh, I don't like that. It's uncomfortable. It's painful, whatever word you want to use. I find that when we do a lysis or a procedure on them, they don't even realize how much it was affecting them because they've been living with it for so long. So once that heals, they're like, my goodness, like I was in so much pain before. I did not even realize how much this was actually affecting me.
There's some data about this too, that if they have keratin pearls, so kind of these hardened dead skin cell lumps that are really tiny. Sometimes they're so tiny, they're hard to actually remove during the procedure. Sometimes I think I need loupes because they're so tiny, but it feels like a grain of sand underneath our clitoral hood. And I find that like when I'm just doing an exam, sometimes I can see the keratin pearls that are stuck in the adhesions. If I touch right on there, they'll say, yes, that is where my pain is. So it seems like these pearls are really a focal point of the pain. Would you agree, Jill?
And when there are adhesions, there's more likely to be keratin pearls because basically what's happening, like you said, is that we are always sloughing off dead skin cells from everywhere. When it combines with sweat and the natural substances that exist down there, they basically ball up. And because of the inflammation and the stickiness of the adhesions, they get trapped either within the adhesion or behind the adhesion. And so sometimes, just seeing one keratin pearl is literally the tip of the iceberg. When you go back with, either a surgical or an office lysis, you will find so many more behind that wall of adhesion. And it's no wonder these patients are in so much discomfort. When people come in with pain, that's a big source of the pain.
Yeah, sometimes there can be a lot of them.
A ton. I usually quantify them as large or small. In my operative report, I will try to say how many. I also take pictures because there's nothing more validating than if you have clitoral pain and everyone's dismissed you, to see a picture and say, those are the little buggers that were causing me all that pain. Like you can see them with your eyes and you're like, this makes sense. It's like having a grain of sand in your eyeball. How long would you be able to tolerate that? And unfortunately, people are living, years with, and this isn't being identified, right? It's enough to drive you crazy.
Little tangent. Sometimes it's not even pain. They can feel arousal from these.
True. Yes, absolutely. They can have persistent genital arousal sensations. This can spark nerve-related sensations. So you can have structural that goes into a nerve realm. The pelvic floor tension can increase, leading to a hypertonic or overactive pelvic floor dysfunction, which can also irritate the pudendal nerve, leading to more of a nerve-related picture as well. So it can certainly snowball and involve other things and kind of become a little more complex as far as treatment. And I do have a number of patients that have structural as well as nerve-related consequences. And we kind of have to calm down both in the process of treatment.
Yeah. I love in your book how you describe how we have to look at this from the bottom to the top and back to the bottom. I think of that every time I'm taking care of patients. It's you have to look at the whole picture.
Oh, absolutely. One thing I do like about treating clitoral pain is I find it to be a little bit more straightforward, honestly, than even provoked vestibulodynia. Like provoked vestibulodynia or vulvar pain right at the opening, dyspareunia or pain with intercourse at insertion. It's similar idea, but it's a bit more complex because you have, 4 different modalities to look at. Whereas clitoral, you really just have 2. So I think that a lot of clinicians can certainly start the process here, or at least validate the patient and send them to a specialist. There's a lot of work that we need to do as far as research to really validate a lot of these things that we see in our office. But I do think this is an issue that can be actually treated quite comprehensively and quite well. We just need the definitive pathway and kind of algorithm, if you will, of how to think about it. And we did. So Rachel Pope and we did publish a review, kind of like a diagnostic piece, talking about the two pathways in obstetrics and gynecology open access, which we really wanted to do because we wanted OBGYNs to really have the manuscript and have access to this. So we published that about 6 months ago, and it has a great figure kind of showing the two pathways. It really divides into structural and nerve related. I mean, it's pretty simplified. So this information is out there. It's like, how do we get it to the masses, though?
So I know that all three of us do in-office lysis of adhesion procedures. I just use like a tiny hemostat. Jill, you do in-office also, right?
I do in-office, and I also do it under IV sedation. So I do OR as well.
Okay. And do you also do like a more surgical procedure where you do like a dorsal slit on the clitoral hood?
Yes. So typically, if someone's less than 50%, or, we're getting away from percentages, but I still use them. So until it's published. So if someone's, I would say, mild, or even mild to maybe going to moderate, I will present them with an option of in-office lysis. So I have a machine in my office that's 50-50 blend oxygen and nitrous, and that provides some of that anxiety, a little bit of pain control through anxiety control. And then I do a dorsal clitoral nerve block for pain control, as well as topical numbing medication. So those are the pain control measures for an in-office lysis that I provide. And then I use a lacrimal duct probe instead of a hemostat. And that's what I use for lysis of adhesions. But if it's more than 50%, so if we're talking moderate to severe, I will typically do it in the operating room, and I do it under IV sedation. So similar to if you were getting a colonoscopy, so IV propofol, so no breathing tube. I actually do it right in my office. I have an OR that's certified by the Department of Health. I have a board certified anesthesiology team that comes to the office one Friday every other month. I line these cases up. I do 6 in a row, and it's fabulous. And so if they need a dorsal clitoral slit procedure, meaning if they need a clamp and cut in the midline where there's fusion, which often people with lichen sclerosis and lichen planus do need because of the level of phimosis that they have. So I do that, or I'll do like a modified version, kind of, a lysis of clitoral adhesions with kind of a modified version of that for moderate. It really depends on the clinical picture.
But it seems like the people who have phimosis, more from like these dermatoses, do better with that dorsal slit. I mean, because I'm thinking I'm lysing adhesions for these patients in the office, and I'm finding, but they're not really adhesions. I'm stretching the hood, and I'm finding that it comes back pretty quickly, even if they're treating their lichen sclerosis pretty well. And I'm now starting to refer them out to someone who could take them to the OR and do a dorsal slit.
So there's a couple of factors involved in this. I do think technique and limitations, right? So I do find that a dorsal clitoral slit is a bit more effective. I do a very conservative trim of any scar tissue, kind of making it more of a rainbow as opposed to, curtains. And so that is helpful. And then it really comes down to prep and postoperative care. The last study that we published on this was 2 years ago, so 2023, and this was data from 2017 to, I guess, 2023 between Dr. Andrew Goldstein and myself. So we were the two surgeons in this New York and DC offices. This was before I came to Tampa. We basically looked at all of our outcomes and looked at validated questionnaires. And of course, FSFI, so the Female Sexual Function Index, a parameter is improved. There was a statistically significant, like 0.001, like real statistical significance of improvement with pain. I think the pain score went from almost 7 to a 2.5. That's really good. And then there was also a statistically significant increase in orgasm. So ability to orgasm, I think it went from like a 5 to a 3, somewhere around there, but it was statistically significant. And so we looked at recurrence rate in that study. And our recurrence rate was about 28%, which I think is on par. I think in the literature, it's about 31% is what's reported. And so My recurrence rate is lower. And I think that the reason for that is because of the pre and postoperative care. Where actually, this is interesting. So that was in-office lysis. So similar to what you do, Ashley, we have almost 100 patients who have had OR lysis. So these are mainly people with lichen sclerosis and lichen planus. We're about to publish this. We're like in the final stretch of like contacting people. And so that one, I believe the recurrence rate is going to settle out below 10%.
Oh, amazing.
I know, that would be incredible. But stay tuned. It will come out. This study will come out eventually. Basically, like I said, so I make sure that any sources of inflammation are taken care of prior, whether that be DIV, whether that be lichen sclerosis or what have you, to the best of my ability. And I make sure that any GSM or hormonally associated vestibulodynia is treated. I will actually have them apply a bit of a estradiol testosterone topical to the periclitoral area, doing some scar tissue release, because when we talk about treatment, surgery is not the only option, right? So I generally break it down into two. I guess there's actually three. It's just one of them I don't offer. So one is manipulation, scar tissue mobilization, and that can be done with the aid of a pelvic floor physical therapist, or that could be done on your own. And I make it easier for people because I have them do it while they're rubbing in a hormone cream. Or, you could consider like, okay, if we think it's bacterial, maybe a clindamycin gel would be, there's no literature on this, but like there's something, right? Or a topical steroid, right? If we believe that it's inflammatory in that way. But anyway, I have them basically apply a topical and do some scar tissue release. And I have had patients have, some success with that. Not a lot. They would have more success if they're moderate to severe. It's kind of tough, but at least they feel like they're making an effort to do something. And if it works, great. And then if it doesn't, their skin is prepped for surgery. So it's a win-win situation. But they basically, so we treat whatever we think is the inciting cause, and they have to have that treated before they start. And their tissue has to be hormonally optimized. And of course, informed consent. So those are my three big things. I mentioned three things there. So scar tissue mobilization, we're talking about procedures, whether they be in office or OR. The third one is energy-based. We don't have good literature on this. I find, at least from looking up websites of people who are doing these type of energy-based treatments for at least lichen sclerosis, many of those clinicians, none of them really publish on it, which is unfortunate, but many of them are doing a hybrid of laser with a release procedure, a surgical procedure. That's what I gather from it. But that's an interesting area of study that we don't really know much about. So there's that. And then as far as post-care goes, that is the most important part. So I have patients basically do sitz baths once a day. This is mainly for lichen sclerosis. I have them apply a topical steroid to the healing area once a day in the healing time period. So the first 4 to 6 weeks or so. I have them retract the area at least 6 times a day, anytime they use the bathroom, just to remind their brain. And I often have them apply a topical hormone to the area as well. So even though, the first, I would say, depending on how strong, how good you are with recovery, the first 3 to 7, maybe 10 days, it feels like you got kicked in the groin, right? Like you're sore, you have an ice pack on, you're sitting on a donut pillow. It's uncomfortable, but it's getting better day to day, right? That's the first week, I would say. This is with OR mainly. The in-office lysis heals, I would say that's like 3 to 5 days, depending on how many adhesions and how aggressive you are. So there's that part of the healing process, which is pretty tolerable, right? People can still work, you might have an ice pack, but it's okay. And then you have the work that you're putting into it. And I have them do the retraction and all the work until I see them for their postoperative visit in 4 to 6 weeks. And so that, I believe, is why I have a lower, and why Dr. Andrew Goldstein as well, in this publication that's hopefully, going to come through. That's why our recurrence rate is so low.
Yeah, I like how you're saying you need to identify the cause of the inflammation. I just find sometimes it's hard when I can't figure out what the underlying inflammatory insult is, even though I know it's there or it has happened in the past. I sometimes find it's challenging to identify that.
It's challenging. And at first, when we were identifying these, we didn't know, right? Like we just had no idea. But, as you see more and more and you start to put it together and you're like, wait, all these people, I look under the microscope for every patient. I mean, that's how I figured that connection out. But you start to put it together. But this is why we need the studies. This is why we need the literature, because then we can say, oh, yes, it is related. There is a correlation between these two things. So if you see clitoral adhesions, do a swab, look under the microscope and see if they have inflammation. Is their pH elevated? Do they have white blood cells under the microscope? Do they have parabasal cells? There you go. You found your root cause. Well, kind of. Even if someone has DIV, you're not necessarily, what is the root cause, right? Like you still haven't found it, but you're going to be more likely to look for erosions on the vestibule or in the vagina. You're going to be more likely to look for a cervical ectropion. And even if they don't present with it that day, you're going to put it in the, in your note, and you're going to track them, and eventually it might come out. So yeah, I think we're going to get better at it. It's exciting, right? It's like the next frontier where we can do research, we can put this together clinically, and then we can share this with other clinicians so we can all do better.
So like when you're talking about when looking on the microscope, just so people know, like, your vagina, it should have a lower pH, and a higher pH is going to be from various things, hormonal changes, inflammation, infections, dermatoses, things like that are inflammatory. And then the parabasal cells you mentioned are just big bloated vaginal skin cells. They shouldn't look big and bloated with big old nucleus. And then white blood cells is obviously, that's a kind of an infection thing in our body that helps to fight off infection. But I'm curious with the ectropion. So the ectropion is, if you don't know, it's glands from your cervix that are kind of out for the world to see on the outer part of the cervix. And the cervix makes mucus, so it should have glands. And in some people, those glands are not visible, but in many people it is. So I'm curious, like, what do you do about it? I mean, because I find some people with cervical ectropion, they might come with like bleeding after sex. Like that's a big thing, but I'm so curious what you do with that.
There's so much work to be done with the cervical ectropion. I can't even tell you. So this is my next project, actually. So this is what I want to do, because I have a bunch of patients that I've identified cervical ectropion. A lot of them have a DIV picture or an AV picture. I've treated it. And then, of course, I've treated their DIV and restored their microbiome, and they get better. We could have a whole session on that. So a cervical ectropion is a normal finding. That's really important. Everyone has a cervical ectropion at some point in their life. When we're young, the glandular cells are more on the outside. As we get older, they typically go more on the inside. And then that area of where they were to where they are is called the transformation zone. And that's where we sample a pap from. Because that is the most common place where HPV can live. And so that's how we detect HPV. Now, what's interesting is if someone has more of a cervical ectropion, they're more likely to express HPV.
HPV loves living there.
And that's why the guidelines have changed. So in younger people, we don't do a PAP until, they're 21 or even old. I don't even know what the guidelines are at this point, maybe even later, just because they all have cervical ectropion. So they all have HPV that come back. And so we were doing unnecessary procedures on all of these really young people in something that was going to resolve on its own anyway. So that's one of the things in the history. If someone comes in with recurrent vaginitis or like a vaginal discharge, yellow sticky discharge, or a DIV picture, and they have a history of abnormal PAPs, that always raises my spidey sense. I always look for a cervical ectropion, but especially, that's an added history, a kind of Easter egg to find. There's a couple ways that you can treat it. In the literature, there was one study, I think it's Andrew Goldstein's study with cryotherapy. I think people have tried that. That's kind of a little bit, sorry, Andrew, it's a little old school just because we're not really taught. I did residency a long time ago. I won't even tell you how long ago, but they weren't doing cryo back then. So that was even kind of before my time. So what I do is I actually treat the cervical ectropion with silver nitrate.
Okay. Yeah. I've done all of the above.
Yeah, that's what I do. And that is actually what I want to go. I have a cohort. I want to go ahead and publish that because I find, at least in my patient population, that I have seen a trend towards improved outcomes and symptoms, but we need to study it to know for sure.
Super interesting.
Always learn stuff from Dr. Krapf.
I know, always. I feel like we've talked a good amount about the adhesions and pain and, sexual dysfunction that come from that. Walk us down the nerve pathway briefly. We've talked about the structural pathway. If you have clitoral pain and it's more, we think we're going down the nerve pathway. What are the underlying etiologies of that and how do you diagnose that?
So what I often tell my patients, it's like being an electrician. I'm not an electrician, but everyone understands this analogy. So if you go and turn your light switch on and the lights don't turn on, right? What are you going to do? You're going to go to the breaker box, right? So you go to the breaker box and you switch the breakers and the lights still don't turn on, right? So then you go to where the street is, or I don't know, to see if the power is coming in the house. The idea here is that with nerve related, we can't see nerves, unfortunately. We can see the vessels around them if we do an ultrasound or so forth, but you really can't see nerves and you definitely can't identify them on physical exam. No, you can push around them and you can get a positive Tinel sign to see where the pudendal nerve's wrapping around the sits bone or the ischial spine. So there are ways to identify these things, but it's difficult. And so when it's nerve related, basically you have the nerves coming from the spine. In the lumbar spine, they break up into multiple different nerves it's the cauda equina, which in Latin means horse tail. I love word origins. I'm like such a geek when it comes to word origins. I just love it. And so from the sacrum, so S, level 2, 3, 4, comes the pudendal nerve, and you have that one on the left and you have one on the right. It wraps right under those pelvic floor muscles. And most importantly, it's wrapped by a saran wrap called fascia. And so if someone has tight pelvic floor muscles that are pulling in, it's going to pull in on that saran wrap and it's going to squeeze or sandwich the nerve in between. And you can get what we call a functional nerve impingement, or basically you can make the nerve moody. It doesn't like that. And you can get nerve irritation from that level. And so these nerves are wrapping under the pelvic floor muscles through like tunnels of pelvic floor muscle and ligament, right? And then they wrap around the sits bone or that ischial spine, break into 3 general branches. The top branch goes on each side to the clitoris. And even though there's anatomic variability, this is consistent, that top branch, right? And then there's a middle branch that's a bit more diffuse as far as anatomic variation. That's going to the labia. And then you have the bottom branch that's going to the rectal area. So in general, that's kind of, it innervates the entire vulva. We always talk about the pudendal nerve, but there's also nerves coming in from the top, coming in from the side. There's some overlap and watershed areas. And I have to say that because my pain management guy that I always send people to, he's like, there's other nerves too. I'm like, yes, I understand, but this is the one I find. So basically, when we're troubleshooting and someone has clitoral pain, it makes the most sense to numb the clitoris at the branch of the dorsal clitoral branch of the pudendal nerve, right? Because it's pretty consistent. And we see if that takes away the pain a considerable amount. Usually we say 80% improvement for even a short amount of time. It could be a few hours, a few days, a few weeks, what have you. That can be achieved a couple ways. You could do a topical numbing medication, but I prefer to do a dorsal clitoral nerve block. Okay. So we usually start there unless there's history that points us higher up in the chain, right? So doing a dorsal clitoral nerve block is like turning on the light switch to see if the lamp goes on. Then we're going to go back to where these nerves exit from the pelvis to the vulva, that ischial spine or that sits bone, because that's a pretty consistent area. When we're talking in between, yes, you can do a peripheral nerve block, but it's like hit or miss. And I've done it. I do the pain mapping. I'll inject and lidocaine and we'll try to figure it out. I've done it before. It's just hard. So then we get to where those sits bones are, and that can be either done through the vagina, which is how we as OBGYNs were taught to do it because it was kind of a early form of pain control in labor before we had epidurals. But I find for my pain patients, that's not a great route to go because they have pain. So if you're going through the vagina, and they usually have tight pelvic floor muscles, so it's just inconsistent with trying to find it and inject a very large needle there. So I usually send them to my PM&R, pain management and rehabilitation friends, who will do a transgluteal approach. So with an ultrasound, they'll look for the vessels around the nerve and they go in the buttocks area. And so then you try that and you see, does that help, right? And then if that doesn't help, then we're kind of looking at the sacral area. We're looking at the plexus, and then you can go higher. And it's in the realm of our pain management friends at that point. It's very possible, and we have some, literature and some consensus opinions to show that you can have disc herniation, Tarlov cyst, a structural issue within the spine or, the lumbar spine, the sacrum, what have you, that can actually affect the clitoris through this same nerve pathway. And it's so interesting to me because when somebody has sciatica, right? So sciatica basically is the sciatic nerve, irritation of the sciatic nerve. If someone says, I have leg pain or I have foot pain with pain shooting down the back of my leg, and it's due to this disc herniation or this slip disc in my lumbar spine, no one blinks twice. Everyone's like, oh yeah, that makes complete sense. But then you say, okay, I have clitoral pain because I have the same thing, just a little lower. And it's like a total mental block. Like no one understands, but it's the same thing. So we often struggle. We can diagnose these things, but trying to get care for them when we get out of the pelvis into the spinal realm, I've found to be a challenge.
Correct me if I'm wrong. Like, we've talked about clitoral adhesions, but the patients that are going to have kind of more the nerve stuff is you do an exam. So you're a clinician. Someone has clitoral pain. You look at the vulva. It looks normal. You don't see signs of a dermatosis. You try to retract that clitoral hood. You're not seeing any reasons for clitoral pain visually with adhesions or phimosis, correct? This is when you start going down that nerve pathway.
You got it. So if I'm not seeing anything structural, then I'm thinking nerve, especially in the setting of hypertonic pelvic floor muscle dysfunction. Now that's functional. If we can release the muscle through pelvic floor physical therapy and other means, which would be a whole discussion, then we can decrease nerve-related pain if it's related to that, right? If we can figure out the true diagnosis, we cannot settle for just saying vulvodynia or provoked vestibulodynia. I mean, we're getting warmer, but we really need to think about how the body works. We need to assign causality. We need to figure out what is going on, whether it's like structural, whether it's muscle related, whether it's hormone related. We really need to do that because otherwise we're really shooting in the dark as far as treatment options. People used to give amitriptyline for vulvodynia. Like everyone used to give amitriptyline. I mean, it's not a great medication, but it probably helps if someone has pudendal neuralgia. If they have a nerve-related component, then yes, amitriptyline probably helps. Now, there's better medications that we use now, but this is just an example. But if someone has a hormonal cause for their pain, the amitriptyline is not going to typically help, or it will help a certain amount, but it's not going to treat what's going on. So I think as we get better with diagnosis, the treatment is actually the easy part.
I think that's like the most interesting, like intellectually part of this job is like what Rachel Rubin calls it. Like we're sex detectives, right? You're trying to figure out, you're thinking about these body processes and these like pathophysiology things. And you're trying to figure out what is the underlying etiology for this pain. Instead of just giving them lidocaine as a Band-Aid or something like that, we're not Band-Aiding here. We're trying to really think through body mechanics, nerve pathways and hormone pathways and try to figure out like, why is this happening to you? And it's complex and it's so fascinating at the same time.
It's really fun.
Absolutely. And that's what sets apart a specialist, right? As a specialist, we are trying to figure out how everything works and we need the time to do so. It really takes time to get to the root of things and to figure it out. I feel very fortunate I'm able to do that. But it's, we have a lot of challenges in our current system with trying to figure these things out.
And so many people get the label and they think, oh, I have vulvodynia, I have vaginismus. And then they come to us and we say, but why do you have that?
Exactly. I know my heart always breaks a little bit when I hear someone's like full story and they're like, and finally I got diagnosed with vulvodynia.
Yes.
And I was like, okay. It's like, okay, well, I'm glad you're here.
Yeah. Yeah, I say that a lot. I'm just so glad you found your way here.
I know. And you know what? We do need vulvodynia as a terminology. We need provoked vestibulodynia because we do need ways to study these things. We need something in like the billing realm, right, to support patients as far as coverage. So these terms, if they get somebody a referral to a specialist, or if they get someone reimbursement, or if they get someone like, if they're a keyword in a research study, then that's fine. That's beneficial. It's just we can't settle for that in the diagnostic realm.
I like that. That's good.
Yeah. Yeah. Well, this has been fascinating. Talking to you, Jill, is just, I always learn so much. I just really appreciate you talking about the clitoris with us and all the things that can go wrong with the clitoris, because again, it's not talked about enough. And I think leaves patients not knowing where to turn with these kind of problems. And I think a lot of clinicians also have no idea how to start this workup, because I don't think I knew what to do. 10 years ago as a generalist, I would have no idea what to do for this. So it's great to talk through these things and just bring more attention to this.
Absolutely. And it's really accessible to get started. Even if you, as a clinician, if you identify clitoral adhesions, you're already ahead of the game. You already did a major service for your patient. So just examining the clitoris is the first step. If we can, I always say this when I'm teaching, if I could give a piece of advice that would increase our ability to diagnose and treat these conditions the most, it would be two things: evaluate the clitoris and evaluate the pelvic floor. If everybody did that, if general GYNs, and we're among them, right? If we all did that, we would identify so many more pain conditions, and we would identify lichen sclerosis and lichen planus much more readily. And it really does not take any extra time to incorporate that into the exam.
It's amazing.
So important. Yeah. So very important.
Thank you so much, Jill. How do people find you?
So I am on Instagram, Jill Krapf, MD. It's not a personal Instagram page. It's really spreading awareness, education, and support for the conditions that I see, treat, and research. I will put a lot of the research on there as well, both what I'm working on as well as other people in the community. I do share to Facebook as well. I'm just not as active on that platform, but a lot gets shared to the private support groups, which I think is very valuable. I do want to recommend the book that we wrote, When Sex Hurts, because it goes through not only in layman's terms, but I think it's a good balance. I think it's great for clinicians of all levels. In addition to obviously patients and their loved ones, there are references. You can do a little more deep dive. It tells you how to talk to patients or how to describe these conditions really well. There's really great analogies. There's also patient voices in there. So actual descriptions of what patients tell us. They're not exact because we're protecting privacy, but it really illustrates the lived experience of these conditions, which if you're someone treating it, I think is very valuable. So When Sex Hurts, I would really recommend, and you can get it with audiobook or in the actual book form. And then as far as appointments, I am accepting new patients. I do have a bit of a waiting list, but I do see patients in person in Tampa, Florida. I have patients who fly from all over to come see me. I feel very fortunate. We have a great international airport in Tampa. It's about 10 minutes from my office, so that makes it a lot easier. And Tampa's not a bad place to visit in the wintertime as well. So have that. And then I do telehealth for international patients.
Well, thank you for being here, and thank you for your advocacy, your research, your education on all these things for both clinicians and patients alike. You're just amazing. So thank you.
Thank you for this discussion. I really enjoyed it.
Thanks for joining us for this episode of Labia Logic.
We get it. Sharing a podcast like this might feel a little taboo, but we're here to break down those barriers. Labia Logic's all about empowerment, not embarrassment.
If you found this episode helpful, we hope you share it with others who could use a little labia logic in their lives. Can't we all? You can find us on all major podcast platforms and connect with us on Instagram at labia_logic.
From our lips to yours,
Viva la vulva!